So again, welcome all of you guys. Welcome to this session, and today this is a continuation of the previous session. Today we'll be discussing mainly on the topic of surface anatomy, right? So the topic for today will be the surface anatomy. So that is the topic today. And this surface anatomy, let me tell you in the beginning that we will be dividing this topic into two main parts, one today and one probably next day. So this is divided into two parts. So first will be today, and second will be probably tomorrow. Okay, so this is an Auricle platform, guys, and we are into the general anatomy and surface anatomy. I will introduce to you a bit of surface anatomy as well. And why to choose Auricle? All these slides and all these features of Auricle are there. We have recorded, we have live, we have exam modules, we have hard copy notes, we have doubt clearing sessions, very important, and we have question bank as well, and practical sessions also. These are the subscription plans. We'll discuss them in the later part or in the end of the session, right? So don't worry much about that. And lastly, last not the least, do also look over here at the code. If you're going for the subscription, which if you need, you should probably go for it. And you can use this code for discounts on all of these subscriptions, right? So we have few plans from foundation to ultimate MBBS. That is from 3 months time to around 4 years time. Okay. Okay, so let's start the topic of surface anatomy, and I will introduce to you this topic also and what does it mean actually. Fair enough. So surface anatomy. To begin with, let us first of all understand that what are we going to deal with this particular topic. It's very interesting, and let me tell you, the sad part is that it is not that much given importance also. Okay, so that's a sad part, but I will let you know that what is the relevance of this. So in just one line, if I may tell you its relevance, then its relevance is that whatever you study in the human body, okay, in the human body, whatever you're studying, that is the anatomy of the human body, anatomy of the human body. If you ask me, sir, what is the relevance or clinical relevance or applied relevance of this whole gross anatomy that we are reading right now, then I would answer that its whole relevance comes out to be the surface anatomy. What is surface anatomy? The anatomy which is projected onto the surface of the body. Simple as that. What is surface anatomy? The anatomy projected on the surface of the body. Okay, so what does it mean? It means that suppose now take few situations. If you go to any physician, for example, you have any fever or you have stomach ache or you have any say cough or cold, whatever it is, simple basic problems you have, you visit a physician. Okay, you visit physician, if he is MBBS, MD, whatever degrees they're having. Physician does a very important part of its whole this examination issue, right? So they will take the history and they will examine the patient, or they will examine if you think yourself as a patient. Now, there are various modalities of examination, right? Either if you have a history of cough, then they will auscultate. They will take their stethoscope and they will look for the breathing sounds in your lungs. And they might also hear the heart sounds. If you have a stomach ache, then they will ask you to lie down supine on the stretcher. They may palpate the abdomen and they may feel for organs like liver, like spleen, and many other things, right? So all of this examination, which all of you guys are going to do in your near future, is based on surface anatomy. You can only do this examination if you know that inside your body or inside a human body, exactly where are the specific organs or where are the specific soft tissues. It does not imply only to the organs. For example, I told you lungs, liver, then you have heart, you have spleen, you have kidneys, likewise, but it also implies to your blood vessels as well. It also implies to nerves as well. Okay, so what is the use of it again? Suppose now, second scenario, you are posted in your hospital's emergency or casualty, whatever you call it as, and normally in casualty, emergency cases come. There is a gunshot injury, there's a stab injury, knife stab, all of that. They might come to you or they come to the hospital. Then looking at the patient and looking at where the injury has happened, you know, okay, if the bullet is going through here, then it might have ruptured inside that particular vessel, or it might have damaged the particular nerve also. So this is only you can have an idea if you have an idea of the surface anatomy. Then only you can take a very good calculated guess over there. So it's useful there. And for most of you who are going to become future surgeons, when you open a body and you take the disease out, then once you are cutting through the skin and the fascia and you're opening, you're looking at a muscle and all, and you're cutting and then you are entering inside whatever layers you are cutting just to reach the diseased area, whatever treatment you have to give during surgery. So you should know that when my scalpel is entering through this area, what structures I might possibly encounter while reaching my designated whichever organ I'm trying to do the surgery on. Okay, suppose you cut the skin and fascia and you're not aware that deep to this fascia, normal anatomy, they have probably a very important blood vessel. And if you're not aware, then it might happen that you might injure that blood vessel or you might cut that nerve which is lying deep. So all of these, I hope you understood the importance of the topic of surface anatomy. That was my main motive. Understand first of all the importance of surface anatomy. Therefore, if you look in your department or you ask your immediate seniors and all, in our practical examinations, right? The practical examinations, we have a separate table allotted to the surface anatomy, where either there would be a cadaver, or if there is a lack of cadaver in your college, a person might be lying supine, or nowadays mannequins are there, or from the labs, and these plastic models are there in the shape of human body. They are placed on the table, and you are asked for a particular surface anatomy. So it's designated. So considering the university exams, considering your PG exams, and considering your whole practical life after you complete with your degrees or examination, this topic of surface anatomy is very important. I hope in the initial 5-10 minutes I gave you an idea what is the importance of this topic. Now we can move on to the surface anatomy. Now, how are you going to approach this? We are going to approach the surface anatomy through various parts of our body. Now, when we start the gross anatomy, we actually divide the body into different parts. What are those different parts? We divide the body into appendages where we have the upper limb and we have the lower limb. Simple. Good thing is we only have to study on one side, other side automatically will be covered in case of limbs. Then we move to the trunk side. In the trunk side, we have the thorax, right? And then we have the abdomen. Okay. That is the trunk part. So now we have covered everything below the neck. So therefore, final part comes is the head and neck. Head and neck. Okay, head and neck. And a bit in the brain also, so that you know if there is an injury over here, if there's a skull fracture, then which part of the brain could have been damaged. So there's a bit of surface anatomy in case of brain tissue as well. That will covered in the head and neck. So these are the 5-6 modalities in which we discuss the gross anatomy, and therefore in these only, with each gross anatomy part, we dig deep into their surface anatomy. So here we are starting with the surface anatomy. The reason is so that we have a good idea of where that particular structure is before dealing into the depth of the anatomy. Now here in surface anatomy, whenever we will talk of the blood vessel, because we will talk of the blood vessel a lot number of times. In blood vessel, basically important are the arteries. I hope you all are aware of what are the arteries and the veins. Arteries are the vessels which are carrying the blood away from the heart. Okay, so normally they have the pulsations. So when you know the arteries, the surface anatomy of the arteries, then you can easily palpate them on your own body to see whether this whatever I'm reading, does it apply to even my body or not. Okay. Or your friends or your roommate's body also, you can palpate the various arteries over there. Then nerves, and also subsequently you will see the importance of it. Okay, so this was just the beginning. So this is the important surface anatomy, and this is how we are going to proceed. We are going to proceed it into a part wise. We are going to discuss the limbs and the trunk and finally the head and neck part. And as I told in the beginning, we have 2 sessions. So one we'll do today and one we'll do probably tomorrow. So let's start with the upper limb and then we'll proceed. So here's the surface anatomy for the upper limb. Here will be a few images over here, and then we'll see. Okay, now with each part, I will tell you its clinical relevance also, so that you have a good hold onto what you are studying and why you are studying and how it is clinically applicable. Just a second. Yeah. So we start with the what? We start with the axillary artery. The good thing is we start with the axillary artery. Now, what is axilla? Axilla is this part, the armpit area. So if I place my hand like this, okay, obliquely over the side of my shoulder, then this whole area is the area of axilla. So the artery that is traveling over here is known as axillary artery. This is our axillary artery, and this whole area, if I may show you like this, okay, this whole area over here, this whole area is the area for axilla. Therefore, the artery over here is known as axillary artery. It's the only artery over there. Now let's see the surface anatomy of it. Now, your question should be, sir, when I'm pressing like this, I'm not able to palpate any artery. So is it that I don't have axillary artery? No, you have axillary artery. Do remember that is another thumb rule of our human anatomy, and that thumb rule is that the arteries, because they are very much precious. So why they are so much precious? Because a small damage and there will be huge amount of blood loss in a very short period of time, and the person may die because the blood in the artery is in a pressure, because the heart is pumping, so blood inside the artery is in quite high pressure, systolic pressure and all that, which you read in physiology. So as the structure artery is precious, it is present deep inside our body normally. Only at few places, which I'll tell you the last part, only at 9-10 places we have the major arteries where we can feel them on the surface of the body. Other arteries are placed deep inside. Then you might think, then why, sir, we are reading this? I told you there could be a gunshot. You might be doing a surgery over this area. So you need to know where the structure lies. So let's see about the axillary artery. So first of all, they are saying they abduct the arm to the right angle with palm facing upward. So palm facing up, abduct the arm to the right angle, right? Artery is marked by a straight line joining midpoint of clavicle. So here is a point number 1. This point over here is a midpoint of clavicle over here. So you can feel the clavicle. Okay, from medial to lateral side. So midpoint of clavicle, point number 1, and junction of anterior 1/3 and posterior 2/3 of the lateral wall of axilla. So what is this anterior posterior wall? See guys, this is the anterior wall, and this over here is the posterior wall. Okay. So if you abduct your arm, you can feel the axilla. You have anterior side and you have posterior side. The junction between the anterior 1/3 and posterior 2/3 somewhat over here, and you have the midpoint of clavicle. This gives you a rough idea of the axillary artery. So tomorrow, if you see any stab injury over here, or any short injury, or any injury over here, then you might get worried. Okay, that artery could have been damaged. Now, suppose there is an injury. Let me give you another scenario. There is a gunshot injury which just passed from here. Okay, just is it that bullet just brushed the top of the shoulder and it went, injuring the shoulder. Now, if you have a knowledge, you know, okay, the main artery is saved over here. The main artery would not have been damaged over here. Okay, so this knowledge helps you there also. Okay, so axillary artery, again, we have to take the midpoint of clavicle, and then between the anterior posterior part of the axilla, it gives you a location of the axillary artery. Try to involve all the information in a practical way so that you remember it for a longer period of time, and that helps in revision also. So this was the axillary artery located in the axilla. Let's see the next one. Next one is the brachial artery. Now, axillary artery lies in axilla. Brachial artery, what does brachium mean? Brachium means upper arm. Brachium means the upper arm. What is upper arm? Upper arm is the region between the shoulder and elbow. So the region where we have the humerus bone, that is the arm region, upper arm. So brachial artery will be lying over here in the region of upper arm. That is the brachial artery. It is just a continuation of axillary artery. So remember, axillary artery was there and it continues down into the brachial artery. So it tells us that wherever the axillary artery will end, the brachial artery will begin from here. If you look at the first point, what it is saying, it is the same thing. Junction of anterior 1/3, posterior 2/3, because here the axillary artery ended. So the brachial artery will begin from here. Okay. And here the image also you can see. This is the point number 1, where the axillary artery ended. So this is the beginning of the brachial artery. And it is reaching where? Level of neck of radius, medial to the tendon of biceps brachii, join the above points. So now this thing over here is very important. I'm putting a star mark. Why? Because here you can easily palpate. Here you can feel the artery. So where it is? Medial to the tendon of biceps brachii. Now, so we don't know about the detail of muscles. No need right now. Let me demonstrate to you how you can feel this artery. Slightly flex your elbow. Slightly flex your elbow and feel the hardest structure in front of elbow. that hardest structure is the tendon of biceps. And then move your finger just medial to that particular tendon. You might not palpate, you might not feel the artery right now, but then straighten your forearm or extend your forearm. Now deeply press at that side only. You will start to feel the pulsations of brachial artery. So you have to first go for the tendon, just go medial to it and then straighten your arm, and then you will feel the pulsation of brachial artery. This is useful. Why? Because daily you have to take, once you reach your clinical postings or internship, daily you have to take so many of blood pressures also. And you have to keep your stethoscope over here. I hope that many of you might have get your blood pressure checked during any normal medical examination. BP is a regular thing to be checked. So there, if you remember, the stethoscope is placed over this middle part of the cubital fossa or in front of elbow. That is where the brachial artery lies. Okay, understood? So this is so important over here. This is the brachial artery. Now, that is brachial artery. But blood reaches every part of the body, that we all know. So now from here, from point number 2, what happens that the brachial artery is coming on nicely like this. Then at the point number 2, it will divide or bifurcate into 2 arteries. One going on the medial side, that is known as ulnar artery, and one going on the lateral side, that is known as radial artery. Okay, I hope you remember radial artery is also palpated right in front of the wrist on the lateral side, that is a radial artery. So let us see their surface marking as well. So here we have the radial artery in the forearm. In bracket is written forearm. Why? Because radial artery will reach the hand also. That will be dealt later. So in the forearm, where is the radial artery? Again, where the brachial artery ended, the radial artery and the ulnar artery will begin from there. I hope you got the point. Brachial artery and both radial ulnar. So wherever the brachial artery ended at point number 2 over here, this is a point where the radial and the ulnar artery will begin. So you can see point number 1 is again medial to the tendon of biceps brachii. Point number 2 is at the wrist between the anterior border of radius and the tendon of flexor carpi radialis. So this is again, let me put 2, 3 question mark over here. Why? Last 2 years, 2 times the question has come. Okay, what was the question? Question was that when you are palpating the radial artery, which tendon lies just medial to it? So here it is written, the tendon that lies just medial to the radial artery at the wrist is the tendon of flexor carpi radialis. This was a famous question that has been making the headlines right now, right? So it is flexor carpi radialis. So here also it is being shown. This is the FCR tendon over here. So it is again, we have to demonstrate it. Keep your hand like this. This is the anterior part of the wrist. On the lateral side, keep 2, 3 fingers like this. Okay, a gentle pressure. You will feel the pulsation. That is the radial artery. Just medial to it. Now, if you do it like this, then you just medial to the where you palpated the radial artery, you will feel again a tendon. That tendon has been asked FCR. So why is this knowledge important? Though I have told you, but again, let me tell you, particularly in which cases this is important. This is important case of suicides. So because a lot of suicidal cases come to the emergency or the casualty. Mental health problem is obviously, you all must be knowing, is quite a big thing nowadays. I mean, it was also, but nowadays we make the diagnosis, right? Suicide is also quite common. And normally for a layman or a non-medical, what we see in movies and all is cutting, slashing the front of wrist. Now the blood will come out, and normally what happens, radial artery lies over here, but it is a bit deeper because you have to put a gentle pressure. So when a person is making a suicidal attempt, then once they will take any blade or whatever they take and start to cut, blood will start to come because blood is everywhere. It is not that only when the radial artery will be damaged, only then the blood will come out. Even if you cut the skin, the blood comes. So in that, their attempt to cut the artery, they will first cut this tendon. And then they will see some blood and they might panic. Then they rush to the emergency. We have seen a lot of cases where they have been slashing of the wrist, but the arteries are all fine. But there's obviously some blood and there is damage to these tendons. You should be knowing, okay, the tendons could have been damaged. Which tendon you are repairing, that also you should know. Na? So the tendon that is just medial to the radial artery is FCR. Therefore, guys, I'm telling you, the questions come from the practical cases only. Okay. Its course is covered with a general convexity, laterally fine. So you know, you understood the radial artery lies from here to here in the region of forearm. Okay, and it is the most commonly palpated artery. Suppose you go to any physician and there's some problem, the patient says some any issue. The first thing normally the doctor does it, they take the wrist and they feel for the radial artery. Because just feeling for the radial artery physiology, it tells a lot of information about the blood pressure, the condition of the heart. There's any difference in heartbeat or not. With the experience, it comes. But the more easiest artery to palpate is the radial artery because it is quite superficial, no, over here, and this area is always exposed. Okay, so that was the radial artery, very, very important. Then we see radial artery in the hand. Now, radial artery is finished in the forearm. Now, from forearm, it will go away into the hand. In the hand, do remember that in the hand, we have two arterial arches. One is known as a deep arch, and one is known as a superficial arch. Though these are basically the palmar arches. And the famous mnemonic over here would be the Dr. Dr. So deep arch is mainly formed from radial artery. Do remember that the deep palmar arch, in the palm we have arterial arches, just to so the arteries might anastomose. Because see, the radial artery is coming like this, the ulnar artery is coming like this. They both will end somewhere. No, when they will end somewhere, they will form the arches over here to supply all these fingers. Those are the two arches. So the deep palmar arch is mainly contributed by the R, that is the radial artery. That is another famous question over here. So I say this mnemonic all the time so that you remember it, Dr. Dr. So let us see the surface marking of it. At the rest between the anterior border of the radius and the tendon of FCR, that we know it was the terminal point of the radial artery in the forearm. So it begins from here in the hand. Then below tip of styloid process radius, proximal end of first intermetatarsal space. Now this again is not easily palpated. Why? Because it is deep inside. Here you can see the tendons. This area we'll see later on. This area is known as the anatomical snuff box. This area over here is known as the anatomical snuff box. We'll deal it later. But this artery lies over here because it ended over here in the forearm. Then it will rush back. Okay, you don't feel the artery over here. It rushes back, means deep to the space. That is the space in the hand. Then it will form that deep palmar arch. Okay, so again, if you have any injury over here, or that, see, that brings me to another famous question. As I told that, okay, artery lies in the anatomical snuff box. So that question has come a lot number of times. You can check it by looking at the previous year questions. The anatomical snuff box is one of the most commonly asked topic in upper limb, mainly for your MCQs and PG exams and next PG and all that. So question normally came what is the content of the anatomical snuff box, and the content of the anatomical snuff box is radial artery, as you can see over here. So this will help you remembering that too. Okay. Okay, let's move from here. Now comes the ulnar artery. So radial artery we have finished in the hand. Now we come to the ulnar artery. Ulnar artery, where will it begin? It will begin from where the brachial artery ended. So again, middle to the tendon of the biceps brachii, it is where the brachial artery ended. So that is point number one. Point number two is the junction of upper third and lower two third of the middle. So just it has a slightly curve over here. But again, you don't feel the artery over here because why? I told in the beginning that the arteries are very precious. If they are throughout their course, if they are superficial, then a small cut over here might risk the life of the person. So nature automatically made the maximum or 99% or 99.9% of the course of the arteries deeper. Veins are superficial. So whenever there is a cut and there is some bleeding, it is normally through the veins. Well, 99.9% of the course of the artery is lying deep. You don't feel ulnar artery anywhere over here. Why? Because it is lying deep to all these bulky muscle bellies over here. But surface marking is this. It goes like this. Then where will it end? It ends later to the pisiform bone. The course is oblique and vertical lower part. Fine. So pisiform bone is where? You all know the carpals over here. This is the pisiform bone, a P-shaped. P means mutter, right? So P, just a small, hardly say how much? 5-6 millimeter maximum diameter of this bone, pisiform. It is a sesamoid bone. Just lateral to it. Now, if you do some deep pressure over here, again, because it's a bone pisiform, lateral to it, you might feel the pulsation of the ulnar artery. But it is easier to feel the pulsation of the radial artery. So it is more commonly felt than the ulnar artery in the case of wrist. So that is the course of ulnar artery in case of your forearm. Okay, remember the landmarks is the pisiform bone over here, where lateral to pisiform. Okay, it is lateral to pisiform, right? Now, ulnar artery, or now coming to the arches, as I told, there are two arches. And I already told you the mnemonic, the DR, the deep and the superficial palmar arches. Here in this diagram, you can see over here, let me highlight. These are the two arches over here. These are the two arches. This one is the first one is the deep palmar arch, other one is the superficial palmar arch. And deep palmar arch, I told, is basically a continuation of the radial artery. So you can see this radial artery, it is continuing, it is mainly contributing to the deep palmar arch. On the other hand, the ulnar artery over here, it is mainly, you can see it is mainly continuing into the superficial palmar arch. Again, guys, if you palpate over here, you don't feel the pulsation of these arches. Why? Because palm is quite a thick structure over here. We have a thick palmar aponeurosis, we have other muscle tendons and muscles. These arches, they lie deep. So what is the use of it? Again, a lot of injuries, a lot of like a nail, the nail can go inside. Okay, any penetrating wound over here that might damage these arches. We should know where these arches lie. Superficial palmar arch, to begin with, a point later distal to pisiform, because DR was the deep palmar radial, so therefore superficial palmar arch is basically continuation of the ulnar artery. Therefore, this palmar arch is beginning where? It is beginning later to pisiform, where the ulnar artery ended in the case of forearm. Then the hook of hamate, the hamate lies just in front of pisiform. On the palm, now this is important, on the palm at the level of distal border of the extended thumb. So this is the extended thumb. Distal border, this will be the distal border, in line with the cleft between index and middle finger. So this is the cleft, this is the index and middle finger, right? So there we have this line. Okay, this is the extended thumb. So this is the area where we have the superficial palmar arch deep inside. Don't feel it. This is the approximate area where you have the superficial palmar arch. Okay, so remember that. Here also you can see the distal border over here. And let me use a different color. Extended thumb, this will be the distal border. This is our superficial palmar arch. Okay, let's move on to the deep palmar arch now. Deep palmar arch is a bit proximal than superficial palmar arch. 4 centimeter distal to the hook of hamate. It lies, this is better actually, 1.2 centimeter, or you can say half inch proximal to superficial palmar arch lies the deep palmar arch. So this distance over here, they are referring this distance to be around half inch or 1.2 centimeter. This is around 1.2 centimeter. This is a deep palmar arch. This is superficial palmar arch. 1.2. I hope you have an idea. Superficial is this. Deep is over here. Simple as that. Okay. I hope point is clear. Palpation of arterial pulses. Now here, some images are there. As I already told in the discussion, the brachial pulse, where we can feel it medial to biceps tendon over here. Most commonly when we do it, while measuring blood pressure. Ulnar pulse lateral to the flexor carpi ulnaris or lateral to the pisiform bone also, where in the wrist. Radial pulse lateral to the flexor carpi radialis, frequently asked question. Okay, so here they are showing us the ulnar artery over here, the brachial artery over here, and the radial artery over here. I urge you, all of you guys, to at least palpate these 3 arteries. Very, very important in case of upper limb. Now comes some nerves. Now, nerves you can't palpate. I mean, there is no pulsation. You can palpate the nerves, few nerves. They appear like a simple, what you can say, simple cord. Okay, without any lumen. You can palpate few nerves. Let's see. Here is the surface anatomy. It does not mean that you can palpate through the entire course. But surface anatomy, median nerve. Median nerve is another very, very important nerve when you study the topic of brachial plexus. So median nerve, brachial artery, we all know where is the brachial artery lying. So median nerve lies very close to brachial artery. So mark the brachial artery, nerve is lateral to the artery in the upper part, is medial to the artery in the lower part. That appears a bit confusing, right? It is lateral to the artery in the upper half, medial to the artery in the lower half. What does it mean? It means that you don't have to worry too much. You only have to understand that suppose this is the brachial artery, which I'm trying to make over here, right? This is the brachial artery over here. Now what happens is that if this is a brachial artery, then this nerve over here will be first lying laterally in the upper half. Then this nerve, it means it is going to cross the artery. And then as it goes down, it lies medial to the artery. That is the information. But what does it mean actually? That is also something that we have to understand. Just a second. Right. So what does it mean? It means that this in the arm region, this nerve and this artery is very important. Okay, now see, in cases of, I'll tell you the practical applied importance of this. In cases of when we do amputations, suppose there's any necrosis or any injury or any machinery injury, we have to do the amputation. Amputation means cutting the dead part of the body, cutting the dead part of the upper limb. Then once you do the amputation, you have to ligate the arteries also. Yes or no? Or else the blood will start coming out and the patient might die. So you have to ligate the arteries always. Therefore, the point comes is while ligating the brachial artery, you have to make sure that you don't ligate the median nerve, else there's going to be a continuous and long-lasting on and off coming pain, different sensation in that stump. Stump means that part of the limb that is left, because the nerve lies very close to the artery. So you have to clearly separate the nerve and the branches of the nerve from the artery, and then you have to ligate the artery. Got the point? And in the cubital fossa, this region, remember, the nerve is needle to the artery. Okay, I hope you got the point. That is the importance of this relation between the artery and the nerve. Here and the nerve also, you are seeing the ulnar nerve. We'll discuss it also. But this is median nerve. Now, median nerve does not end over here only. It has to reach the hand. Okay, it does reaches the hand. It gives sensory sensation to the lateral 2/3 of the palm, sensory sensation. So the median nerve will reach the hand as well. Now, in the forearm, what is the surface and not in the median nerve? It is quite wide dotted because again it lies a bit deeper. So point medial to the brachial artery of the neck of radius. Fine, we got it because it ended over there in the case of arm. In front of the wrist, this is where it is important. 1 centimeter medial to the tendon of FCR. So do remember over here, we said this is the FCR tendon. Okay. Lateral to it, there was an artery, and medial to it, there is a nerve over here. Okay, let us label this. This is lateral, that is medial. This is the FCR tendon. Again, you can feel the tendon easily. This is the radial artery. Again, you can feel the pulsation. And medial to the FCR, this is the median nerve. This is the median nerve. So what is the importance over here? Again, in suicide cases, when you are slashing, the nerve can be damaged. Another, more importantly than that, is that this median nerve, as it proceeds down, it lies below a structure or beneath a structure that is your flexor retinaculum. So in this area, this median nerve can easily be compressed, and this is quite common. If you attend the orthopedics OPD, you will understand median nerve over here can easily be compressed in different cases. In old age, in diabetes, in thyroid, idiopathic, without any reason. And that is known as carpal tunnel syndrome. I'm sure some of you might have heard of it. If not, then okay, you have heard of it now. And as you will proceed further in your studies, this term will come again and again a number of times. Carpal tunnel syndrome. This syndrome is due to the compression of the median nerve in front of the wrist. And what is the treatment of it? You can't give any medicine, right? You only have to do this opening up of this area so that median nerve gets more space. So you do this bit of small surgery over here. So you can do the surgery only if you know what structure you are looking at. So you should know where the median nerve lies. So now, other thing, let me add one more thing over here. Other thing is, one is this applied aspect, very important, guys. You learn, maybe some of you have realized. If not, then later on you will realize how important is this topic, carpal tunnel syndrome. Other thing which I wanted to point out over here is that this median nerve, its name, why do we call it as median nerve? What does median actually mean? In anatomical terminology, something in the midline is known as median. Yes or no? And anything that is close to median is known as, it is more medial. So median is exactly in the midline. Medial is closer to it. And what we call lateral is more, in comparison to the medial, it is more away from the median structure. So medial lateral, we all know. Central line is the median plane. So if you look at the forearm, this median nerve lies somewhat in the mid plane of the forearm. Therefore, its name came from here. Why do we call it as median? In the wrist also, you will see somewhat it is lying exactly at the center. at the center over here. So its position is quite middle in the case of long axis of the forearm. So we call it as a median. I hope you got the point. Median. Why do we call it as median? Okay, so therefore its location is important, right? So that was a median for you. Now let's come to the vein. Now vein again, not very important, because veins, if they are damaged also, they'll be bleeding, but the rate of blood loss is quite less. You can easily compress, but you should know where are they actually lying, because it doesn't mean that you keep on injuring the vein. So to begin with, we have this cephalic vein over here, cephalic vein. Cephalic over here does not mean it is going to the head, it is going to the head and neck. Okay, cephalic vein is just a terminology over here. It does not mean it's going to the region of the head. We have two veins over here. We have a basilic and a cephalic vein. Just remember, if you see the forearm over here, the vein which is lying more medially, this is the basilic vein. The vein which is lying more laterally compared to the basilic is the cephalic vein. Just remember this thing first of all. So this is a laterally lying vein. And as we discussed earlier on, that the arteries are more precious, so they are naturally placed deeper inside our body. Veins are comparatively less precious and they are more in number. There are so many tributaries of veins. Therefore, compared to the arteries, these are more superficial. You can feel them, but they won't give you any pulsations. You can see many veins. You can see on the back of the palm, the dorsum of the hand. You can see some veins. You can see some veins in the forearm as well. You can see some veins in your dorsum of foot. All those vessels that you see are veins. You can easily feel them, but there are no pulsation in the vein, because that is a major difference. Now, how to see for the cephalic vein? Cephalic vein, it lies in the anatomical snuff box. Let me change the color over here. Right. So it begins. So the arteries we studied coming from proximal to distal. We started from here: axillary, brachial, radial, ulnar, and hand. Veins begin from distally and then they'll go towards the heart. Because by definition, veins are the vessels which carry blood towards the heart. Okay, so the start where cephalic vein start where at the anatomical snuff box. This was where this was laterally. Remember the thumb side, that was anatomical snuff box. The radial artery was laterally. Anatomical snuff box laterally. Cephalic vein, as I told you, laterally. Then in front of the elbow, in the groove between brachioradialis and biceps, here to lie in the deltopectoral groove below coracoid process. Now this is what it is important over here, and that can be asked as a question. What is this deltopectoral groove? Let me show you in this particular image only. You'll understand. See over here, this is the muscle deltoid. I guess most of us know this rounded contour of shoulder. This is the deltoid muscle. And the front of chest, this muscle over here is the pectoral muscle, pectoralis major. So we have a deltoid muscle, we have a pectoralis major muscle. Now, if you feel for your own body, if you slightly flex the arm, you see there is a difference, or there's a groove between these two major muscles, because these two are not as small muscles. These two are major muscles, big muscles. You can feel the groove. And therefore, this cephalic vein, it lies in this deltopectoral groove over here. Let me point out, this is the area where the cephalic vein lies. And it is quite superficial over here. And this is the place which is also one of the most common places where any injury can happen. Or if you are giving any incision over here to operate on the shoulder joint or the axilla, you have to give an incision around here. You should know, okay, if I just go blindly, like cut the fascia and like this, I might easily damage the cephalic vein. But if I know, okay, it is a very big vein which is lying over here, so I might just cut slowly through the skin fascia, then retract the vein, then go deeper. I'll be saving a vein. You're getting a point. So understand these small things that will make you a good doctor and also help you in clearing the exams as well. Okay, so this is the location of the cephalic vein. Most importantly, I'm again saying, out of all these landmarks, this is most important, lies in the deltopectoral groove. Okay, and anatomical symbols to lie. But some of you might think, if you are listening very carefully, which I am sure most of you are listening, that sir, a few minutes back you said that anatomical snuff box, the content is cephalic vein. Or no, I said the content is radial artery, right? Then isn't the cephalic vein also a content of anatomical snuff box? Or is it only the radial artery? Why can't cephalic vein be a content? Is it or not? Answer is no. Cephalic vein is not a content. I'm writing over here. It is not a content of anatomical snuff box. But sir, it is lying in an anatomical snuff box. Yes, it is not a content. I didn't say it is not related. It is related, not a content. Then what would it be? Cephalic vein will form the roof of anatomical snuff box. So a small space over here. Cephalic vein is close to the skin. Why? Because it is a vein. So it is close to the skin. It is a superficial vein. There are deeper veins also. There are few veins which are flowing with the brachial artery. They are known as brachial veins. Those are deeper veins. But the cephalic and basilic vein, the B for basilic vein over here, B is basilic vein. These are superficial veins. So they are close to the skin. So the cephalic vein will not be a content of anatomical snuff box. It will form the roof of anatomical snuff box. Remember this small, what we can say, technicalities of anatomy of the human body, right? So remember this, cephalic vein is not a content. It's a roof of the anatomical snuff box. The only content of the box is radial artery deeper. Okay, cephalic vein, then they are very, very important vein, median cubital vein. Now, whenever you see such a sort of big names like long names, median cubital, okay, what? Cubital fossa is the region in front of the elbow. So this region over here, let me show you. This is the cubital fossa. Now the vein lying medial over here or just in the center will be known as median cubital vein. And why is this important? It is the most common vein for, we can say, intravenous sampling. Okay. Now, many of you must have given your blood for various blood tests. You might have seen lab technicians coming to your house or your room to take blood from your relatives or friends or yourself, whatever. This is the most commonly sorted out vein from where the blood is taken. Intravenous blood sampling to check the various levels of any test, you name it. Why is this vein so commonly used? For a couple of reasons. First of all, it is easily accessible. You can see in this particular photo how easily you can actually see this vein. You don't need to read about its surface anatomy. It is shouting out from here only in the image, right? That I'm present over here. The second thing, the reason this is most commonly used is that it is quite fixed wherever its location is. It does not move here and there because beneath it, there lies a bicipital aponeurosis. So there's a, let me say, a strong connective tissue sheet below it. So there is a sheet below, and over it lies this median cubital vein, and this is sort of adhered to this sheet. So it does not move here and there. Because if you are seeing this vein, the moment you put a needle, then vein might move here and there a bit, like 2-4 millimeter here and there, and needle is searching the vein. It rarely moves. So it is quite fixed, and you can easily take the blood from here. That is why this is the most commonly used vein for intravenous blood sampling, median cubital vein. It is joined between two veins. One side over here, we had which vein? Laterally, we had cephalic vein. Medially, we had basilic vein. It is sort of connecting cephalic to basilic. And both are superficial veins. Even not both, but all these three veins. Cephalic, basilic, and median cubital are superficial veins. So let us now see the landmark. A 0.2.5 centimeter below the lateral side of the elbow, a 0.2.5 centimeter above the medial epicondyle. So from here to here, they have marked this is the region of the median cubital vein. But you can easily palpate if the person is not very muscular. Let me tell you, even then, what we normally do, we put a tourniquet over here, or we just tie some band over here so that the venous return is impaired for a few seconds. Then we ask the patient to make a fist so that more venous blood is returned from here and is obstructed. So the venous blood is accumulated in this area. Then once you have placed a tourniquet, then you start to feel over here. Okay, you won't feel the pulsation, but you will feel some elevation, soft elevation in the center of the cubital fossa. That is the region of median cubital vein. That is very, very essential, guys. There was a lot of, not a lot, but any patient who is admitted in a hospital due to any reason, even for one day, you have to take some blood samples, no, to check for various blood levels. This is a commonly sorted out way. And the more you practice it, the more you have a good command of taking the blood out of this mean cubital vein. Okay, now let us see some nerves also as well over here. Axillary nerve again will lie where in the region of axilla. So the couple of landmarks over here, it lies where in the tip of the acromion process. So this is the acromion process. It is like in the highest point of the shoulder laterally. It lies over here and it goes where insertion of deltoid. So insertion of deltoid is this. The horizontal line 2 centimeter above the midpoint of the above point. So you have to, you can see, ask the patient to abduct, from here to here, there's a deltoid. You can actually feel it. It is quite a big muscle. And just take a midpoint of it. There's a midpoint. Okay. And 2 centimeter above the midpoint. Fine. But sir, why is it so important? No, that question should be coming into your mind, I'm sure. Okay, that fine, sir, it is between acromion and deltoid. We take a midpoint 2 centimeter above, fine. But you start to cram it and then after 15-20 minutes, half an hour, you forget it. But what if I tell you its importance? Importance lies in giving intramuscular injections over the deltoid. Remember COVID vaccinations? Mostly given here only. And therefore, couple of years back when the whole COVID and all was at its peak, a NEET PG question came for this particular nerve only, that a person was unable to abduct and there was some different sensation over here after receiving COVID vaccination and all. Some question was related to this only. Because while giving intramuscular injections into the which muscle? Deltoid muscle, if you don't know the basic surface anatomy of the axillary nerve, your needle might go and insert or damage the axillary nerve line in the deltoid. Okay, so you have to probably, you can give intramuscular injection, but beware of this location. Don't give the injection near this location. That is the whole point. Okay, but axillary nerve can easily be damaged or irritated while giving vaccination intramuscular injection. Now, ulnar nerve in the arm. This is one of the rare nerves which you will see is easily palpated. I will show you how. A point, now say a few points, a point on the lateral wall of axilla at its lower limit, fine. Middle of the medial border of the arm. So you have the medial border of the arm and the middle of it, somewhat over here, and behind the base. This is the point. Let me highlight it. Behind the base of the medial epicondyle of humerus. This is the medial epicondyle now. Let me demonstrate to you guys. This is the region of the elbow. Okay. Medially, if you palpate, you will see a bony projection. It is a prominent projection. You can easily feel it. There's only one projection. That is your medial epicondyle. Now, what you do is you move your finger behind the medial epicondyle and try to roll slowly. You will feel a cord-like structure. And that cord-like structure is the topic over here, that is ulnar nerve. You are actually feeling the ulnar nerve where just behind the medial epicondyle. Just behind the medial epicondyle. Fine. So that is the location. What is the use? Again, not now, but a few years back, a couple of decades back, leprosy cases, this nerve used to enlarge. So when we used to go in a skin clinics in MBBS time, our faculty, sir, in the skin department, they used to palpate all these ulnar nerves, and we were practicing this nerve and the accessory nerve, the spinal accessory nerve over here, this nerve, and one more nerve in the lower limb, that is a common peroneal nerve. These three nerves we used to palpate, and these nerves are actually site enlarged in case of leprosy patients. That is the thing of a bit past, but nowadays its applied importance would be because this bony projection is quite prominent. So anyone falling on the ground, medial epicondyle can be fractured. In case of fracture of medial epicondyle, this nerve can be damaged. Ulnar nerve can be damaged. Remember that. Okay. Fair enough. So ulnar nerve we have seen. Ulnar in the forearm also. Again, it will start from behind medial epicondyle, lateral to pisiform. Lateral to pisiform is one more structure. What structure was that? Remember? Later to pisiform, we also studied ulnar artery, and just along with the ulnar artery runs ulnar nerve. Remember this. And therefore, if I may recall, not recent, but 2017 or 18, 6-7 years back, there was an image a cadaveric image was shown in which both ulnar artery and ulnar nerve were there, and arrow was placed on one structure. I don't remember because I didn't give the exam, but students have different thought process. That's why the arrow was on the ulnar artery or the ulnar nerve. So both of them are close by, and how to see which one is which? So do remember over here that ulnar artery over here is more what we can say more on the median aspect, or it is lateral to the ulnar nerve, which is more medial. Okay, because both are present over here, so ulnar artery will be over here like this, and just adjacent to it you have this ulnar nerve over here. A very small structures. Because in image you are not able to palpate, no. If it is in your exam and all, you can feel this, okay, it has a lumen, it is an artery, it has no lumen, it is a nerve, fine. Then there it is easy. But in the exam, you have images in your computer screen. They should know. Okay. Now finally, we have the radial nerve also. Radial nerve is your largest branch of brachial plexus. Radial nerve is your largest branch of brachial plexus. First of all, information is this. Is the largest branch of brachial plexus. Brachial plexus is the whole nerve. Is the whole nerve station of the upper limb. This whole plexus, which is supplying every part of the upper limb, largest part. So where do we see radial nerve? Lateral wall of axilla at its lower limit. That is point number 1. Do remember, radial nerve is supplying the posterior portion or behind posterior aspect of the entire upper limb. That's the whole point. So majority of its course is lying posterior. Therefore, in this image also, if you see, it is showing us the posterior aspect of the upper limb. So the points over here are lateral wall of axilla, junction of upper 1/3 and lower 2/3 of a line joining the lateral epicondyle and insertion of deltoid. A bit tricky, but do understand that radial nerve, suppose this is the bone that is a humerus. Suppose the head of humerus, and here you have the tubercles. It is going down like this. Okay, and there is middle epicondyle and the lateral epicondyle. This radial nerve is actually crossing on the posterior aspect of the humerus. And this is where we call this as the radial groove. If you look at the humerus bone, once you study the humerus bone, you will encounter a radial or also known as a spiral groove. It is for the course of the radial nerve. That is also shown over here. So point number 2 is junction of the upper 1/3 and the lower 2/3 of a line joining. This is the lateral epicondyle, and let's say this is the insertion of deltoid. This lateral epicondyle, 1/3 and 2/3 of it. Just to give you some points. On the front of the elbow now, surprisingly, it moves a bit in front of the elbow, below the lateral epicondyle, 1 centimeter lateral to the tendon of biceps brachii. So in front of the elbow, this is the imagine brachial artery. I am going from where to where? Let me tell you one more thing: medial and lateral. Which area we are looking at? We are looking at front of the elbow, that is cubital fossa. This is what? This is brachial artery. Medial to it, what we have? We have which nerve? Median nerve. Okay, if you are well versed by now, which tendon is this? Biceps brachii, a huge tendon. And then lateral to it, you have a small part of the radial nerve in its course, which comes. So now let us label all of them. If going from medially, we have the median nerve. Let me use the black color over here. This is the median nerve. Lateral to it, this is where you palpate. This is the brachial artery. And this is obviously very strong structure, tendon of biceps muscle. And lateral to it, this is the radial nerve over here. These are the 4 important contents of cubital fossa. Lying in front, obviously, of the elbow, that is cubital fossa. 4 important contents. Okay, MBBR is the mnemonic. If you want to remember the mnemonic also, going from medial to lateral, we have MBBR. MBBR, medial to lateral. Okay, here you can see the radial nerve. But what about its course below? In the forearm, guys, it actually terminates into what we call as posterior interosseous nerve, that we'll see subsequently. Okay, now comes the flexor retinaculum. I just mentioned this flexor retinaculum, where when we discuss the median nerve, and then I talked of a syndrome, carpal tunnel syndrome, where I said that the median nerve has high chances of getting compressed in front of the wrist deep to this flexor retinaculum. So now this is, guys, understand, this is a very, very common thing. It's a very, very common thing that you'll see in a lot of orthopedics, OPD or OTs if you just see. In a busy hospital, normally there can be 1 or 2 cases every week. They can be. So carpal tunnel syndrome. Therefore, while doing surgery, you have to release the nerve from this flexor retinaculum. So you have to release the retinaculum, obviously. But this is what is compressing. You should know where it lies. So the easy part is that this flexor retinaculum, if you know the name of carpals, you know the attachment. So there are 8 carpals, 1, 2, 3, 4, 5, 6, 7, 8. And this flexor retinaculum is attached to the 4 corners of the carpals. The 4 carpals which are placed on the corners. Now, what are those 4 carpals placed on the corners? Here you have the scaphoid. Okay, scaphoid, lunate, triquetral, and pisiform. And from here we have the trapezium, trapezoid, capitate, and hamate. So these are the 4 borderline or the corners of the carpals. So you can see it is lying where? It is lying pisiform, scaphoid, hamate, and trapezium. Just remember this one. It is attached to these 4 carpals. Exactly proximal border. You can see over here. See, wrist. When we say in our wrist and when we say carpals and all, sometimes we think when you don't have a complete in-depth knowledge. This is the region of carpal. This is not the region of carpal. This is the region of the lower end of radius and ulna. Okay, then feel for the styloid process of the ulna and feel for the styloid process of the radius. This is where the radius and ulna are ending. Therefore, carpals are lying over here. So where is retinaculum? It is over here. The median nerve is being compressed over here. This is the location of the flexor retinaculum. Okay, this was superficial arch, deep arch, and this is flexor retinaculum location. Okay, so do remember that. It is quite important, flexor retinaculum. Similarly, we have on the back, we have an obliquely lying extensor retinaculum. So let us see where it lies laterally. Laterally is this part, point number 1 over here. Lower part of the anterior border of the radius, lower part. And so it is a bit oblique. Medially, it goes up till the pisiform, triquetrum, and the ulna over here. So it is a bit oblique. It's a different topic in itself. But yeah, the syndrome is related to the flexor retinaculum, that carpal tunnel syndrome. That is not related to the extensor retinaculum. Here, what you will learn later on are the various structures, because here, this extensor retinaculum is actually divided into 6 compartments. That is a different topic altogether. I'm just giving you an idea what is going to come later on. Okay, that and what is passing through it. So it's a 2 centimeter broadband directed downwards and medially. Okay, as you can see, downward and medially. Now comes the anatomical snuff box over here, which for your various purposes is quite important. So you seeing the diagram. I ask all of you to just extend your thumb and you can see the tendons over here. This is the anatomical snuff box. You see a concavity, a depression over here in the backside of the hand, the backside of the first metacarpal, because it is bounded by two or not just 2 but 3 important tendons. One tendon is going over here. This is extensor pollicis longus. Let me label it extensor pollicis longus. Feel this tendon, it will extend the thumb. It is going to your thumb. And these 2 tendons over here, these tendons are abductor pollicis longus and extensor pollicis brevis. I'm not writing the complete name, just telling you over here. And where exactly is anatomical snuff box? This place. This is your concavity. Why we call it as snuff box? Because you people who used to take drugs and all, they used to keep the powder over here and they used to snuff like this. From there the name came. Anatomical snuff box. Bounties are this. If I again ask you what was the content of anatomical snuff box, I hope you won't forget it after today, because we are discussing it for the 3rd time. The main content was, or the only content is, the radial artery. That's it. And you can see it over here. Again, sir, fine, but is there any applied use? Yes, a lot. Apart from directly cutting and damaging, these tendons over here, do remember these tendons which you are seeing over here, they are always and always covered by what? They are always and always covered by a tendon sheath. And there is a disease. There is a disease when this tendon sheath, sheaths are inflamed. In those cases, the movement of thumb is quite painful. It is quite common. If suppose someone starts to use their thumb or in some job too much. I mean, they are lifting any weights too much or whatever it is. So there, in those cases, there can be inflammation not of tendon, but the covering of tendon. And that disease is known as D. curvans is the name of the scientist. But the main disease is tenosynovitis, tendon sheath, synovial sheath of tendon. So tenosynovitis, it is the inflammation of the synovial sheath of the tendon, tenosynovitis. In that case, again, if it is not getting, the pain is not going on its own, because normally it goes on its own. But if it doesn't go on its own after a few months, then you have to again do a surgery. You have to again relieve the synovial sheath. And you have to cut a scalpel, small through scalpel, you cut the synovial sheath of the tendons. So again, you should know the anatomy, right? Okay, so that disease is known as D. curvans tenosynovitis, just a small applied which I gave you over here of these tendons, right? Therefore, this is one of the reasons why it is again very important. Now, guys, so yeah, this was the upper limb. So today, in the beginning, we only discussed upper limb. Tomorrow, we'll discuss the lower limb and the atomic part as well. Okay, so don't worry. This was the surface anatomy part, and let us just review in less than a minute what we discussed today. That is important, right? So we start with this axillary artery, the region of axillary artery. Applied importance I gave you. Again, doing surgery. Now, where a lot of surgery is being done in this area. Breast cancer, the most common cancer in women worldwide, not just in India, worldwide, is breast cancer. In breast cancer, the lymph nodes are lying in the axilla. You have to remove those lymph nodes. Again, you have to reach this structure. Then axillary artery, after that, we came to brachial artery, applied. Needless to say, we have the BP measuring. Okay. Then we came to the radial artery again, pulse normally taken from here. Then in the hand also we saw anatomical snuff box. Then we came to ulnar artery, from where to where it is lying. I also told you the question. Then we discussed the two arches, which is one more proximal, which is more distal. And remember the mnemonic DR doctor. Okay. Then palpation of few arteries shown. Then nerves. I told you applied aspect, amputation cases. Just revisit whatever I told you. It is very important clinically. In the forearm, then carpal tunnel syndrome, and why we call it as median cephalic vein in this area. It's quite important. You are making any cut over here, do remember not to damage. Then we have median cubital vein, the most commonly used vein for taking the intravenous blood sampling. Okay, axillary nerve, IM injections, intramuscular injections. Do remember ulnar nerve in the arm. Okay, middle epicondyle fractures. Again, this is important. Then in the forearm also we have seen radial nerve, the largest branch, mainly lying posteriorly. So as this nerve is, one applied also, I just happen to remember, as this nerve is very close to the bone. Now, so what happens is whenever there is a fracture shaft of humerus, fracture what? Shaft of humerus, or fracture of epiphysis, or fracture of diaphysis of humerus, then this nerve can be injured, because it is actually in touch with the bone. Normally the other neurovascular structures, they are slightly away from the bone. They are having some muscle can be in between, some fascia can be in between. But here, at few places, like the radial nerve over here, the ulnar nerve behind the middle epicondyle, they are very close. They are very close to the bone. Even the axillary nerve over here is close to the neck of humerus. Remember that also. Then we discuss the retinaculums, both the retinaculums. Then we discuss lastly this anatomical snuff box. Very, very important, right? So guys, that was it. And let us just go back to these subscription plans. I hope you take the screenshot of this. And also you can use the code if you wish to log in for that. You will get some attractive discounts. So we have some plans over here. What are these different plans? Let me just change the color. Yeah, with this foundation plan for 3 months, with the advanced learning plan for 6 months, complete learning plan for a year, and the ultimate MBBS plan. Normally in these 3 plans, all the features of the app you will get. In the foundation plan, you won't, you will get majority of the features like recorded classes, live classes, express exam, practical, and question bank. Majority, most of that. But what you will miss over here is the hard copy note set, and you're going to miss the doubt clearing session. This is what you will get, and on these 3 plans, you're getting all of it. Okay, choose wisely. All of these are the features of the app over here. And let me tell you personally, the hard copy notes are very nicely made, and all these sessions, they are, needless to say, very important. So guys, that's it for the time being. I hope you enjoyed. And do keep revising. Any issues, any doubts, do reach out to us. More than happy to help you out. That's all. See you soon with another session on the surface anatomy. Bye.